We're going to talk about the skeletal anatomy relevant to what we call a cervical sympathetic chain block, and also the cervical selective nerve root block or extraforaminal injection. The reason the skeletal anatomy is important because when we do the scanning, you're looking for the bony silhouettes which will help you to identify the targets. Now, when we use the ultrasound, I always recommend using the high-frequency linear ultrasound probe and scan from the midline to lateral side. Midline structures you will locate would be tracheal rings, and we will also visualize the thyroid gland, and then you will move laterally. When you move laterally, the first bony landmark you will see will be the C7, depending on what level you are, but the C7 or the C6. Now, the bony silhouette of C7 is different because C7 lacks an anterior tubercle. There is no anterior tubercle. You only have posterior tubercle. On contrary, C6 has anterior tubercle and the posterior tubercle. So the bony silhouette you get with C7 is what I call is as a lounge chair or a deck chair position, where you only have posterior tubercle but no anterior tubercle. But when you look at the C6 or C5 or C4 level, when you have anterior tubercle and posterior tubercle, this is where you have your nerve root resting. At C7 level, you have a vertebral artery going through the foramen transversorum, and the nerve root is resting next to it. So it's very important to consider this anatomy when you're considering the injection of the selective nerve root block or a cervical sympathetic chain. Now, when you talk about cervical sympathetic chain, we usually perform the block at the level of the C6 instead of C7 because you have vertebral artery that's exposed and you have nerve root. C6 level, when you put the local anesthetic and sit the patient up, the local anesthetic will spread along the gravity and will reach onto your stellate ganglion, which is located at the C7 T1 level. So you have two muscles, you have a longus colli and you have a longus capitis, and between the two muscles you have middle cervical sympathetic chain at the C6 level, and once you put the local anesthetic into that area, it will track down and it will get your stellate ganglion, which is located at C7 T1 level, and this is where you would block your middle cervical sympathetic chain or the stellate ganglion. When you talk about the extraforaminal injection, now when we use ultrasound, we never go transforaminal because you're not going into the foramen. You're looking at the bony silhouette of anterior tubercle, posterior tubercle, and you bring the needle from posterior to anterior in plane, and you will stop at the posterior tubercle, and you will then inject dye. You will use the X-ray to make sure that the needle is not in the vessel. Even though ultrasound is very useful to find the vessels, sometimes the vessels are so small. So it's always better to use a combined ultrasound and fluoroscopy technique. And once you've confirmed that the needle is not inside the vessel, then you'll inject the local anesthetic and non-particulate steroids like dexamethasone to perform the extraforaminal injection. So just to recap, start from the midline, scan, move laterally, look for either C7 or C6. C7 level, you don't have an anterior tubercle, you only have posterior tubercle, and you have vertebral artery that's exposed here, and then you have C7 nerve root. At the level of C6, you have an anterior tubercle, posterior tubercle, and the nerve root is basically between the two. Same thing happens at C4 level, C5 level, you have anterior tubercle and the posterior tubercle. And when you're performing the extraforaminal injections, your needle endpoint will be at the posterior tubercle. And when you are performing stellate ganglion block, we usually put the local anesthetic in the middle cervical sympathetic chain and allowing the local anesthetic to spread down with the gravity and blocking your stellate ganglion, which is situated at C7 T1 level. And that's what you would consider the skeletal anatomy relevant to these two blocks. Thank you. I'm going to show you how to do ultrasound guided middle cervical sympathetic chain block. To perform this block, you will start to scan the patient from the midline scanning, and always recommend scanning the midline because it will allow you to look for the familiar structures. So here on this image, you will be looking for the tracheal rings, and then you have thyroid gland, and you also can see a lot of blood vessels that are supplying the thyroid gland. Once you have seen this image, then you will be basically moving your ultrasound laterally, and when you see, you will be able to see the vascular structures of carotid artery and the internal jugular vein. So midline scanning is always useful. Another advantage of a midline scanning is you will be able to see a bony landmark which will tell you you're looking at the cervical vertebra, and this is most likely C7 cervical vertebra, because at this level you don't have the anterior tubercle, so you can see the straight line and you can see the posterior tubercle. Now the difference between the C7 and C6, C6 has anterior and posterior tubercle, and now we're going to start to scan up, and now we can see the anterior and posterior tubercle along with the nerve root here in this image, and I'm going to freeze this image and I'll be basically showing you. So that's the C6 nerve root here, and then you have an anterior tubercle and you have a posterior tubercle. So this is the posterior tubercle, anterior tubercle, and the C6 nerve root. So it's always important to look at that structure, and below the carotid artery you have a muscle, and that's the longus colli muscle. So it's very important to look for these structures and locate the levels, and then you can look for the muscles. The other important structure here you can visualize is a hollow structure, which is the esophagus. Now, how do we know this is esophagus? You can actually ask the patient to swallow. So can you swallow for us, please? And you saw a flash in that hollow tube. So it's the esophagus. That confirms the esophagus is on the left side in this particular subject, and it's next to the trachea. So you have the esophagus, and then you have also seen a bony landmark, which is a C7 vertebra. Now we're going to move up, and we're going to move his neck laterally. When you ask the patient to look on the contralateral side, you're moving all the vascular structures. If you bring the neck in the neutral position, you will have more vascular structures in your view, and your longus colli muscle will be below the carotid artery. But when you do this, you'll be moving away the vascular structures away from your target. So it becomes much easier to target the muscle. Now in this view, you can nicely see the longus colli muscle, and we are now going to move up, and you will start to see another muscle that's coming into the view, and I'll show you this on here. This is the longus capitis muscle. That's the longus colli muscle. The small dot you can see, that's a hypoechoic area. That's a vagus nerve in the carotid sheath, and your area of interest is the prevertebral fascia. And you bring the needle in plane, go below the prevertebral fascia, you inject 5 cc's of local anesthetic and steroid mixture, and then you sit the patient up, and this is your middle cervical sympathetic chain which you're targeting, but the local anesthetic will flow down and cover your stellate ganglion. So just to recap things again, start at the midline, move lateral, look for the thyroid gland along with the blood vessels. You have the esophagus in that area. You move lateral, you have a C7 vertebra, because you can see the vertebral artery pulsating. Now we are moving up. When you move up, you will see the anterior tubercle of the C6 along with the longus colli muscle. And now we just slightly moved up, and now you can see the longus colli, longus capitis, and the prevertebral fascia. Your needle approach would be in plane from posterior to anterior, or lateral to medial, bringing the needle in and going below the prevertebral fascia, injecting 5 cc's of local anesthetic and steroid mixture, and sitting the patient up, allowing the gravity to float the local anesthetic onto the stellate ganglion. Thank you.